So a graduate student working for, I think it was for Victor Papanak, but it may have been somebody different. A graduate student actually came up with this idea initially of just, well, why don't we just print it on a paper tape? So if you're green, you're good. You can wait for treatment. If you're yellow, you're sort of on the borderline. Red needs immediate treatment. So basically, you can print these things out on a laser printer, and it dramatically decreases the amount of time and resources required for doing triage with infants. I mean, we like this kind of simple solution. Figure out what you need and don't do anything more elaborate than that. So for us, we started by looking at the clamp that does flow control for an IV drip. And this is just a cutaway, so you've got the tube going through this clamp. There's a roller that goes back and forth to pinch the tube shut. This is the, I don't know, the $750,000 cartoon. Here's a cutaway drawing of a standard clamp. And what we realized is that with the tube lying on this flat surface, again, this is a cutaway drawing, as you move the clamp to pinch this shut, the flow rate as a function of the roller position was nonlinear or non-proportional or non-intuitive. So I move this halfway and there hasn't really been any significant change in flow rate. I move it 3/4 of the way, still not a very significant change, and then all of a sudden it goes to all the way shut. Unfortunately, infant treatment in particular tends to happen around this area or this regime of flow control. So this device is totally non-intuitive, particularly if you don't have a medical background. Nurses who use these all the time are familiar with the fact that when you're doing flow control for very low flow rates, you have to make these very tiny, imperceptible adjustments. So we just looked at this and said, well, this is linear and this is non-linear, so what if we switched it? I mean, what if we came up with a surface such that if I move it halfway, I get half the flow rate? How is it in the almost 200 years that this device has existed, nobody's ever thought of that before? I don't know. But we got a bunch of patents. This product's in development. I think we have a picture of what it looks like now. So obviously, in going into manufacturing, there are a lot of adjustments to make it actually work the way we want it to, but this is now scaling to hundreds of thousands of units. And really, it was that basic insight about if this is an important part of the drug delivery process, how can we make it more intuitive for people who may be using it for the first time? So I'd like to talk a little more detail about our process before giving you some information about my background. So this is a project we're currently working on for infant incubation. And is everybody here familiar with an infant incubator? Sort of just in general, the most, go ahead. So the most important thing that this does is provides temperature control. Both for term infants who are sick and for premature infants, really, you want a kid to, you don't want a child to be wasting calories, the food that they're eating, on maintaining their body temperature. You want to apply those calories towards getting fatter and healthier and bigger. So really, right now there are 4 million kids a year who are dying before their first month of birth, and half of those kids, so about 1.8 million children, if all you did was keep them warm, they'd make it. 99% of those kids are in poor countries. So great, let's give them all incubators. Well, the problem is this is an atom. It's manufactured in Japan. We found this in Nepal during a field study, and the top of the line GE giraffe incubator costs about $30,000. And when you think about cost, there's cost to buy. Well, cost to buy goes away because these are all donated. If you go to pretty much any pediatric care facility in a developing country, they'll have a bunch of donated incubators. Some hospital in Japan probably just bought the next or the newest model incubator and donated all of these overseas. So the cost to buy is zero, but then you look at cost to own. So if I gave all of you Ferraris, you would have a phenomenal month. And then you get a flat tire and find out, oh, $5,000 for a tire. Really, it's cost to own that's an issue. So there's a group at Duke University that did a study that something like 95% of donated medical equipment is broken within 5 years in poor countries. And I'll explain a little more. I mean, this is what we want to offer to these kids. This is actually what a lot of the kids in poor countries get. So this is the only pediatric hospital in Nepal, in Kathmandu, and this is one of their neonatal infant care units, intensive care units. All of these kids belong in incubators, but they don't have enough incubators for all of these kids. So instead, they're swaddled in blankets. These boxes on top of their heads are to provide oxygen. And again, what you can't see is there's actually 18 kids in this ward, and there's 2 nurses. In fact, at night, there's only 1 nurse. And it's not unusual for the night nurse to sort of wake up in the morning and discover that 2 kids have passed away. They don't have anything in the way of heart rate monitoring, temperature control, oxygen monitoring. So that's not great. But in fact, some kids are even worse off than that. So this is a picture from a Burmese refugee camp on the Thai-Burma border. And again, this is a child that belongs in an incubator. They're actually using, so the team that was there doing volunteer healthcare had a bunch of medical equipment that they were planning to bring into the country with them. They couldn't get it through customs, but perversely, a couple weeks later, some laptop computers that they'd ordered arrived from Dell just sort of out of blue. So they're using the bubble wrap that came with the laptops as a way to try to insulate this baby. So this is a big issue. All we need to do is keep these kids warm and clean. Clean would be nice too. And so our question is, well, how can we do that for less money? So really, our process is to start at the beginning and say, again, that's a big problem. 1.8 million children. Are they all the same? Do they all have the same needs? Are they all existing in the same context? So we start by trying to understand, well, who actually delivers infant care? What's their world like? So this is a rural doctor in Nepal, sort of a one-man band, does everything from births to adult care in this community. Here's his one assistant. So really, this is the person whose life we're trying to figure out. How do we make this person's job easier when it comes to infant care? And as I said, as we looked around, we find we're trying to understand, well, what's the state of the art in terms of donated incubators or the space of neonatal care? So this is taking a tour of some of the neonatal care facilities in Kathmandu. You'll see that all I want you to see here, these are two different models of incubator. And this is in the same room, kind of turning 60 degrees, and you can see that there's a third different model of donated incubator. We found some of these donated incubators. So this one was in a storage closet. It worked fine, but it's in French. Nobody speaks French. Nobody wants to figure out how this works by burning. It's just donated doesn't necessarily mean appropriate. Similarly, donated incubators. So this is a 1950 model GE incubator. It looks like an easy bake oven. I don't know who did that power cord repair there, but that's a little scary. They can't afford to throw this away. So they're actually still using this for infants because it's so rare that they get donations that, they have to keep the ones that they have working. So that's not great. What's the repair issue? Well, this is, in most developing countries, this is like state-of-the-art repair facilities. This is the most accomplished repair facility that you'll find anywhere in the developing world, the auto repair yard. If you think about what gets fixed in a developing country, I mean, cars live forever. They're in a kind of state of constant breaking down, but these are the people who fix things in developing countries. So one of our initial questions was, well, what do they know how to fix? And how do we make what we're building look more like something they know how to fix? If this is what we're going to have to rely on for our repair resource. And one of the consequences of having a very limited repair resource is that every healthcare facility that we visited around the world has these donated equipment graveyards out in the back where, some of these are waiting for like a 35-cent fuse that you just can't get in Nepal. Or in some cases, they've got equipment that's pretty ratty, but they're hanging onto it just in case they get another one. And then they can maybe cannibalize some spares out of this. So, and here's our scary GE, I think it's horrible. Okay, so for us, the first step in beginning the product design process is to come up with what you call a point of view. And really it's, this user in this context has this need. And as we look, and this is sort of bringing coals to Newcastle, I'm sure you've got an analogous process that you go through in product design. But for us, the point that I want to make with the point of view is that it's less about what it says than what it doesn't say. This is true also with starting a business. In the beginning, when you start a business, in the beginning when you're designing a product, it's much more about saying what your product doesn't do, what your business doesn't do, rather than saying what it does. So it's important to notice, for example, that we're focusing on infants who are 32 weeks of gestational age or older. Turns out that kids that are born more than or less than 32 weeks premature have so many other health issues that temperature control alone is not going to help.